Oh, well, good morning, everyone, and thank you so much for taking the time to be here with us today. We truly appreciate your presence, your support, your continued commitment to the work of Dementia Alliance. Whether you're a longtime supporter or joining us for the first time, your partnership makes a meaningful difference in the lives of families across North Carolina and beyond who are navigating dementia. Today's webinar gives us an opportunity to share what's been happening with Dementia Alliance over the past year, the programs we've strengthened, the families we've served, the community we've built, and the ways and generosity and involvement have directly impacted real lives. Our board remains deeply committed to our mission, and we are so proud of the dedication, heart, and hard work of the team brings to an important cause every single day. We'll also touch briefly on what's been happening in the broader scientific and research community around dementia, and Kathleen will be sharing more on that later in the program. We're grateful to have a chance to come together with you, reflect on our progress, and look ahead to our next chapter in the journey. And with that, I'd like to turn that back over to Lisa.
Thank you, Tara. Hi, everyone. Sorry, doing double duty here. It is so good to see all of you today and to see you come into the webinar. I'm Lisa Levine. For those of you that don't know me, I'm the Interim Director of Dementia Alliance. And we are just thrilled to have you together with us for this update today. We wanted to give you a little peek inside of what's going on, both with our programs, our plans, and most importantly, with our research update from Kathleen. So a little bit about what we've done this year, and you'll be probably all of you receiving this in your mailbox or your email box soon, but we wanted to let you know kind of our numbers from 2024, 25, and then what's going on 25, 26. So in 24, 25, we helped about 700 families through our navigation program. And for those of you that know, that means resource referral, it means one-on-one talking and counseling, and it means just generally family support. We helped to give over 1,000 hours of respite assistance to families across the state. Along with our partners at Project Care and Life Care Respite programs, we were able to help about 4,500 of you through our direct education programs, that being webinars, workshops, and conferences. We grew to 165 support groups this year, and we were so thrilled to get up to that number. That's the highest that we've been so far. And we know our big goal is to have a support group in every county, and we're pretty close to that. We have 63 counties covered right now, and we trained 106 new facilitators last year, and even more this year already. So excited about that. Overall, we've helped about 14,000 people in North Carolina. And part of that help, of course, was our music and memory program. We gave out about 90 music kits this year. One of the exciting things that I wanted to share with you is we are expanding our music program. Our music program overall is now going to be called My Music NC. We are going to continue to have the Music and Memory at Home program. We will still be sending out music kits for free to families living at home, but we are developing software that will be available on our website very soon so that you can go in and make a personalized playlist for your loved one living with dementia right on our website. You'll have all the tools that you need, the information that you can type in, and then you'll get a list for your Spotify account or if you have another streaming account, we'll make it so that you can get that information too. So we're going to be bringing music to more people in 26 and moving forward than we ever have before. We've done so many of these music kits and they've made such a difference for loved ones living at home, but we wanted to be able to bring that joy to other people as well, to people maybe that are living in care facilities, or you could even do one for yourself if you wanted to. So we wanted to make sure that we brought that personalization and those very pointed playlists to everyone. A couple of other new things that we've done this year that I really wanted to highlight for you before we jump into anything else. We have started a new support group training in partnership with Duke Dementia Family Support Program. We did a training for our current facilitators who were interested in leading support groups for people living with dementia. That was a first for us, and we look forward to doing more of that with our partners at Duke Dementia. We had a great response, and in just a couple of months, we already have one group started. And we have more on the way. So we're thrilled to be able to meet the needs of folks living with dementia in a more supportive way. And we hope to build that across the state as well. We have done much more education outreach, and right now we are targeting rural areas, underserved areas, and areas that we have not been in as much. We've done more outreach in the western part of the state and some of the eastern counties that don't have as many resources, and we really look forward to getting into more and more of those counties as we continue to work in 26. And of course, you've all heard about accepting the challenge. We rolled that out in 2025. We had that DVD from 20 plus years ago, and we made it into a streaming platform. And now we have so many of you that have joined and watched that material with us, and you're sharing it with people. It's free for families living in North Carolina. There is a small charge for people outside of North Carolina. There are credits available for professionals who want to watch that. The website for that, in case you haven't heard of it before, I'm not sure how that would happen, but it's www.acceptingthechallenge.org. And it's easy to click and type in your information and get all of that. At the holidays, if you're going to be seeing family, it might be a great time for you to go ahead and get the link for accepting the challenge and to be able to share that with your family. There's a lot of good information about how to interact with loved ones living with dementia that could be helpful for all of us while we're visiting with our family. We did want to share a little bit of some of our priorities for going into 2026. You know, we're all planning for the new year. One of those is, of course, helping to expand access earlier in the diagnostic journey. Dr. Welsh-Bohmer will talk more about what's going on in that area, but we will really especially look forward to working with our partners across the state to help that happen. We are working on deepening our relationships with healthcare providers and getting them information that they can share with families as soon as they're diagnosed, so no family feels alone through this process. And of course, we are working to build a state of caring. You know, in our tagline, you see our logo all over the place, but we call Dementia Alliance, it's a state of caring, and North Carolina is a state of caring. And it's so important that we all work together to support these families. It takes all of us. Everyone on this webinar is we call you family members, whether you're actually a family caregiver or professional, you are a member of the DANC family. And it truly takes all of us to care for everybody across the state. And so that's why it's so important that we learn about this information today, that we share together, and that we all come together to support not only ourselves, but these families as well. So, with all of that being said, I'd like to take the spotlight off of me and turn it on to Dr. Welsh-Bohmer. We are so thrilled to have you with us today, Kathleen. You have been our go-to for research and updates for so many years now, and we truly appreciate you joining in today and bringing us some news that I bet a lot of us haven't heard yet. So Kathy, I'm going to turn it over to you.
Great. Thank you, Lisa. And I know it says Morgan is my name, but Morgan gave me access to the meeting. So you'll see two Morgans on this call, but I'm Kathleen Welsh-Bohmer. It's really great to be here today and great to see so many people attending. I hope you can see my slides. I just put them up. Let me know if you can't.
Yes, we can. We can
Okay,
see.
great. So first, I just wanted to run through real quickly the statistics. Many of you may already be familiar with the statistics of the current problem that we're dealing with across the nation, but also here in North Carolina. Kind of wanted to set the stage with what the current figures are. So as our baby boomers continue to age into the age of risk, we're now looking at 7.2 million Americans affected by Alzheimer's disease. It's estimated to be the sixth leading cause of death behind heart disease and cancer, accident, stroke, and then other kind of chronic respiratory diseases. Then Alzheimer's is the sixth leading cause. Currently, it's costing us just in Medicare and Medicaid dollars, $384 billion in annual healthcare costs. This does not take into account the costs that are associated with providing care. So we're looking at 16.2 or more million unpaid caregivers. And you could basically take that healthcare cost that you just see to the left and double it when you factor in the costs that are associated with providing care that caregivers are shouldering, often having to leave the workforce in order to take care of a family member or a friend who's affected by a cognitive disorder, Alzheimer's, or another dementia. Without a cure, we're looking at actually by 2050, it says 2060, but absent a cure by 2050, we're looking at over 14 million people being affected by Alzheimer's disease. This will come at a healthcare cost of over $1 trillion, as you can see here. And we'll see just a ballooning of the number of people who are involved in providing care, with over 45 million unpaid caregivers helping to accommodate for the growing population of people with cognitive problems. Here in North Carolina, we just had some new facts and figures released in April. It's estimated that there's 211,000 North Carolinians affected by Alzheimer's and related dementias. Without a cure, we're looking at a big increase, going up to about another 23.5% affected. So our numbers will really be quite high in 2050. And again, there'll be more caregivers involved with providing the care. Right now, we're estimating that this could be quite high. And again, with families having to take most of the impact, paying for approximately 70% of the care dollars that are going into the care of people with Alzheimer's in the state. So that all sounds pretty dire, but I'm here today to say that actually I think the good news is outweighing the bad news. So we now have treatments that are available for mild Alzheimer's disease. I'll tell you a bit about those. There's a blood test that's on the very near horizon. There's also more than 139 drugs that are in development, and I'll show you a bit about that. And importantly, we now have evidence that there's ways to reduce our risk for developing Alzheimer's and related dementias and measures we can take right now to maintain good brain health. So first, I just wanted to focus in on a few of these new findings. So the first is the blood biomarkers. So we get asked a lot about what's happening in this arena. And I spoke to you last year over one of these coffee hours about the advent of new blood biomarkers that are now becoming available. These are designed to measure the abnormal proteins that occur in the Alzheimer's disease brain. Those two proteins are called amyloid and tau. And there's quite a big body of research now over the last 20 years in particular that suggests that a form of tau, we call that tau 217 or phosphotau 217, is very specific to Alzheimer's disease and it can be measured in the blood. So tau 217 or phosphotau 217 is actually a very good indicator of both those proteins, amyloid and tau, and is highly accurate in distinguishing Alzheimer's from other forms of neurodegenerative dementias, such as frontotemporal dementia or Lewy body dementia. So it's very sensitive and specific as well. So the FDA approved a new test for general use in May of 2025 that looks at the tau 217 and also measures plasma levels of the amyloid beta protein. And this test has become clinically used in specialty clinics. So these would be neurologists, geriatricians, and other specialists who are seeing patients who have concerns and symptoms suggesting perhaps they have early stage Alzheimer's disease. It's currently not available to primary care doctors. However, just recently, in the past several months, Roche announced that their blood test would become available through LabCorp. And they just announced this in October that this Alzheimer's disease blood test, it's measuring a very similar tau protein, and this is called the tau 181, and that's going to roll out to primary care in early 2026. So this is on the very near horizon. This has some advantages over the current methods for testing for Alzheimer's disease, which involve either a spinal tap or a PET scan, which obviously come with costs, quite a bit of costs, and are not as convenient as just having a blood test. Currently, the blood test is not yet covered by Medicare or private insurance, but we're hopeful that that will occur. Should these blood tests become available as we expect, this will now provide primary care a mechanism for screening people who come to their office with memory symptoms and then providing information that would allow them to refer on to a specialist for further diagnosis, and also provide reassurance to people who have memory concerns but don't have evidence of Alzheimer's disease. So once we determine that somebody has a cognitive problem and has Alzheimer's disease, what can we do about it? And I mentioned that we have some drugs that are now available for the mild stages of Alzheimer's disease. This is a really busy slide, but every year a group out of UNLV pulls together all the data within clinicaltrials.gov, which is a website that all drug manufacturers must register their drugs that are under development. So they kind of concatenate all that information together. And currently we have 139 different drugs that are in development. It's busy here on the slide. If you look at these concentric circles, you'll see the different phases of drug development. So we have 3 basic phases of drug development. The first phase, or phase 1, is that outer concentric circle. And those are the drugs that are in just the very early development stage, then in testing in humans. And then the phase 2 are the next stage of testing. So once they've passed through the phase 1, if they look like they're promising, they come into phase 2 for some early safety work. And we call that also signal finding work to see if we can pick up potentially a signal from these different compounds. And then phase 3 is the really rigorous clinical trials that we bring into the clinic. And so what you can see is that in each of these concentric circles, you see a lot of different dots and they're different colors. And what I find really exciting about this, the colors indicate the mechanisms of action. And so you see that there are different drugs that are targeting different mechanisms of action, different biology, all related to the development of this very complex disease, Alzheimer's disease. So the red dots that you see are targeting that abnormal protein amyloid. The dark blue dots are the ones that are targeting tau. And then you can see some green dots that are more of a vascular mechanism. And then there's some yellow that's getting at inflammation and immunity. So we now have a very large arsenal of different compounds that are under drug development and moving closer and closer, hopefully, towards that inner circle of phase 3, and then hopefully finding them to be successful, that they might then become available to the general public as something that would help with Alzheimer's disease. As I mentioned, we have a couple that have passed through these different phases of drug development and have reached FDA approval because they showed some evidence of having a mild effect in Alzheimer's disease. The two that are currently available by prescription are Leqembi and Kisunla. Both of these are what we call monoclonal antibodies, and they're targeting amyloid, the amyloid protein. They involve either monthly infusions or biweekly infusions. So Kisunla is a monthly infusion and Leqembi is biweekly. Requires close safety monitoring because there is some safety concerns with both of these drugs. And the costs are now covered by Medicare, although there are some considerable out-of-pocket costs that come with these compounds. And you can see that I've circled them here because they're now undergoing testing even in earlier stages of Alzheimer's disease, potentially as a therapy that might prevent the occurrence of symptoms earlier in the disease process, in the biological disease process. So we know that Alzheimer's disease is caused by pathology called the amyloid plaque and the tau tangles. And you can see some of this is in this little circle here that shows all the different kinds of pathologies that can occur in the brain within Alzheimer's disease. And so those drugs that I was showing you are designed to attack these different pathologies that can occur together. So you can see amyloid is at the top of the circle here, and right next to it on the right are the tau tangles. But there's also other things that are happening in the brain. And some of those things that are happening in the brain are pathologies that are associated with other forms of dementia. So we can have alpha-synuclein, which is affected in Lewy body disease. And then we can have atherosclerosis and infarcts and lacunes that are associated with vascular disease. And all of these pathologies tend to co-occur with Alzheimer's. It's very uncommon for Alzheimer's to occur in isolation. So we're beginning to realize that in treating Alzheimer's disease, every patient is going to be different and will have its different components of these pathologies involved in their brain. And targeting just amyloid alone will not be a real good strategy for all patients. We may need to have multiple combined therapies in order to really be effective. And that's why all these different drugs that are in development are so encouraging right now, because our thought is, as we get further down the line, that we'll be able to develop personalized treatments for every patient, targeting the exact signature pathology that's involved in each individual case. One of the drugs that we were really looking forward to hearing the results about were these GLP-1 drugs that we're probably all very familiar with. These are the drugs that are behind weight loss drugs like Ozempic and Wegovy. And recently, 2 trials being conducted by Novo Nordisk called the EVOKE and the EVOKE Plus trials were looking at these compounds in slowing Alzheimer's progression. We just heard this week, unfortunately, that it appears that this particular form of the GLP-1 drug is probably not going to be effective in Alzheimer's disease treatment. They did report that there was some biomarker change. We haven't seen the report yet, so we don't know exactly which biomarker they're talking about. And this was a treatment that was started in mild cognitive impairment, which is the early stage of Alzheimer's disease. So we didn't see any clinical benefit coming from that, but there's a report that some of the underlying biomarkers may have been changing. And so what I would say is that while this is obviously disappointing news, we'll know more in December, early December, when we get to see the full results from this study. But we know that there's other drugs within this class that are under scrutiny right now and are in trials, and they seem to have a slightly different mechanism of action. So while they do regulate blood sugar levels like the GLP-1 that was used here by Novo Nordisk, they also have other effects on blood flow and brain inflammation. So we're hopeful that maybe some of these other compounds will have an effect. What we're now seeing within the last couple of years is that there's been a step back where the research and what's happening in clinical practice is moving to say, why don't we take a look actually at the underlying disease mechanisms and move more towards trying to reduce risk and optimize brain health rather than manage by giving a drug once the disease has fully expressed. And so there's quite a bit of attention now on what can we do, and because we do understand more of what's happening in the brain, what can we do now before the symptoms express, or even if they have expressed, how can we potentially slow it down so that function is maintained and optimal brain health is maintained. Oh, I think I went the wrong way. And so we know that actually there's quite a bit that we can do to reduce the risk of developing vascular disease and Alzheimer's disease. And these different factors all relate to what's important for our heart health can also be very important for our brain health. So we've known that vascular risk factors contribute both to dementia risk and are drivers of Alzheimer's disease. And many of these conditions are actually modifiable. So they can lead to cardiometabolic conditions like diabetes, hypertension, high cholesterol. And we know that if we could intervene and have an impact on any of these different factors, that we might actually be able to not only to affect heart health, but also brain health. And in fact, there's quite a bit of evidence that this is in fact the case. So this is the most recent Lancet report that came out in 2024 that showed that there's a host of different risk factors that we encounter over our lifespan, that if we could prevent those risk factors, we could actually delay dementia cases by 45%. And so this graph right here shows that there are a variety of different factors that occur either in early life, midlife, or even later life, that if we were to take action on them, we could reduce the overall risk of developing dementia. So in early life, education seems to be a good buffer. And probably that's related to developing what we call neural redundancy, or many connections in the brain that help us to buffer things that might happen to our brain over our lifespan. In midlife, there are a variety of different things that you can see listed here, but you'll see some of the ones that I just mentioned: physical inactivity, diabetes, smoking, hypertension, obesity. All of those contribute to brain health problems, and if we could intervene and reduce those problems, we also reduce the risk. Later in life, over ages 55 and 65 and older, factors like social isolation, exposure to air pollution and visual loss, also hearing loss, can contribute to the cognitive disorders that we see in later life. Again, if we remedy those, we can help to reduce some of the risk. And so basically, I've boiled these different factors down into 7 different things that can be done now based on the evidence to reduce our risk of disease and potentially have a benefit, both in terms of memory decline and dementia progression. And so the 7 things are listed here. One is basically a mindset change, taking control of our health, treating what we can treat. So identifying any of those medical problems that I just quickly mentioned and trying to reduce them by either stopping things that are interfering with our health and addressing those underlying health conditions. The strongest evidence to date actually comes from getting physically active, and I'll tell you a little bit about that in just a moment. And also quite a bit of evidence that our diet is very important on our overall brain health. We also focus on working our brain, so keeping it engaged, learning new things, engaging in social activities, very important for brain health. Attending to things like emotional health and sleep, also very, very important. Sleep is when we reduce all the neurotoxins that are accumulating throughout the body, but in particular through the proteins that are accumulating in our brain that are abnormal. So that's when things are getting cleared from our system. So it's very important to pay attention to sleep and make sure that we're getting adequate rest. And finally, I always like to put the seventh key component, which is getting involved and staying involved in brain health research. And actually, this is a really great way of taking charge of one's own brain health is by staying informed about what's happening. So just, I'm going to quickly just go through two of these because there's been some news. So physical activity, very, very important. Meta-analyses have been done over the last several years and show repeatedly the same findings, which is that exercise can delay cognitive decline in people who are already having some memory problems. And there's also been quite a bit of evidence that exercise might actually help in people who have not yet begun to have memory problems. There's a biology to support it. So we see changes in brain structure and brain tissue function and in the biomarkers associated with dementia. So all seem to be responding once either people or animals that have been tested get physically active. We see changes in the positive direction in the biology of the brain. Hot off the press, scientists at Massachusetts General Hospital just released what I would call actionable information. So they have shown that individuals keeping track in a very large study, they showed that having more than 5,000 steps per day can actually slow the tangle pathology that occurs in Alzheimer's disease. And they observed this very large cohort over 14 years, and they were able to show that by maintaining a step count of at least 5,000 a day, not only had an effect on the tangles, but also slowed the cognitive decline that they measured in people. And the strongest signal that they were able to see were in the people that had been sedentary who are now beginning to exercise. So again, that they could show it was having an impact on that amyloid protein that's affected in Alzheimer's disease. And this was published in Nature Medicine. It's actually quite a remarkable study. With respect to diet, there have been at least 15 clinical trials that have looked at dietary interventions, and they have found a significant effect on cognitive performance. Although it's been mixed as to whether or not diet could actually prevent dementia, it has been shown to have a positive effect on cognition. And the diets basically have been shown across a variety of different cultures. So we often hear about the Mediterranean diet or what's called the MIND diet, which is very similar to the Mediterranean diet. But we've also seen it with other diets that have been published in Asian cultures, Latin American, African American. What we find is common with all of these healthy diets is that they're focused on plant-based food groups, fruits, vegetables, beans, seeds, nuts, and lower on red meat, more with the healthy seafood such as salmon, the fatty fish. And the World Health Organization recommends really it's important to have the balanced diet rather than trying to get our vitamins and nutrients from over-the-counter approaches. Here are some of the ways to get started. I think many of you are probably familiar with some of these recommendations. So it's really about getting that balance of nutrition from our diet. And I just wanted to close by pointing out that it's possible that even by taking small steps, we can have an impact on our overall brain health. These were the results that were just released this year from the U.S. Pointer study, which is headquartered out of Wake Forest University. It was a 2-year clinical trial that looked at a combined intervention of physical exercise, healthy nutrition, cognitive exercise, and monitoring those health conditions that I mentioned at the top of the talk here. They did the trial in over 2,000 older adults. Some of the individuals got this intensive, structured, multi-component training that focused in on the 4 parameters that you see there. And another group got what we called a self-guided approach, where they were given recommendations, but were left to do these things on their own. The intensive structure group actually had health coaches that helped them through the 2-year period of the trial. But what they found that was really exciting in this study is that they saw cognitive improvements in both the groups, and not just in that very highly structured program. And the findings were very encouraging, suggesting that even with these modest changes in lifestyle factors, we can protect our cognitive function. The effect size that they saw from this intervention was as strong as what we're seeing with our drug treatment. So again, this was giving us a lot of encouraging news that we can take control of our health and have a very positive impact, even over as short a 2-year period. Finally, I would just want to close by saying staying informed and involved in research is really important, and it's easy to do here in North Carolina. We have what's called the North Carolina Registry for Brain Health that's here at Duke University. It provides you with the latest updates about what's happening in research, and also provides you opportunities to get involved if you're inclined to get into different studies. So I would encourage you to go to our website and join if you haven't done so already. It's free. It's just an information exchange that allows you to know what's happening here across the country, but also here in North Carolina. And so I would say get informed, get involved, join us at the North Carolina Registry for Brain Health. And I'll thank you for your attention, and I'll be happy to take questions.
Thanks so much, Kathy. Looks like we've got some questions coming into our chat right now. And one of those is, can the lifestyle changes that you've spoken about help people that are in their 60s that already have some risk factors like high blood pressure, high cholesterol?
Yeah, absolutely. So actually, we find the strongest signals when people start in midlife with these habits. So we've followed large cohort studies over the years, and seeing that these interventions that lead to healthy hearts are leading to healthy brains. So the Framingham Heart Study is one of probably the longest running studies that have shown the health benefits of healthy lifestyle. We know that there's, it's harder perhaps to see the changes in people that are already experiencing memory problems, but when we measure memory over time, we do see that there's a benefit even in people who are already beginning to experience memory problems. So we would encourage everyone, regardless of whether you're having a memory problem or not, to get active. As humans, we're constructed to be upright, to be walking. And I think the recent study that came out of the Massachusetts General Hospital is just saying, get those steps in. It doesn't matter that you're running. It's really just getting those steps in, getting active.
So we all need to get stepping. Okay.
Steps in, yeah.
That after turkey dinner walk is going to be really important this year.
Indeed.
Great. So you talked a little bit about the blood tests, and we have one that you said is more for specialty clinics, and that's measuring both tau and amyloid. And then the new one by Roche is just measuring tau. Is that going to make a difference in diagnostics at all?
So, I mean, the new test that's coming out is highly specific as well. So they're both looking, it's measuring a slightly different, what we call isoform of tau, but it is very sensitive, and the data are quite impressive. So they've been improving these assays over time. What was surprising to us is that sometimes the measurement of these different forms of tau are also giving us an indication of what the amyloid is likely to look like. So amyloid is the protein that actually is affected first in Alzheimer's disease. So it starts to aggregate first. And then tau, when we get a heavy enough or when we get a large enough level of abnormal tau, the disease has already progressed. So that's when both are occurring in the brain, but when we begin to measure the tau, you can already kind of assume that the amyloid has already started to accumulate as well. So it tends to lag a little bit behind the amyloid. So the tau 181 is actually picking up on both protein levels. So both are looking good. I think the challenge that I see going ahead is really not so much in the blood test itself, but then what happens after that. And so I think having these tools will allow the primary care doctor to be able to screen and say, it looks a little abnormal. We may need to run some additional tests to make sure that we're not overcalling it, because it's a way to screen to see that if there's a likely problem, but then it's an indicator for additional tests. So if you screen negative, that's a good sign. If you screen positive, doesn't mean that you have the illness. It just means that it needs to be explored further. So I think that's going to be, I think the biggest challenge is going to be then getting referrals into specialty clinics or to have access to the additional tests to be able to say with confidence it's Alzheimer's or it's not.
So right now we know that between a primary care visit and a specialty clinic, we're looking at often a 6 to 9 month waiting time. Do you think that with the advances in all of this, we may get some more folks that are interested in specializing perhaps in neurology and maybe decreasing that wait time by having more access to providers?
Well, we would hope so, right? Because I think you can kind of do the math in your head that as the number of people get screened, for example, the number of specialists will need to increase the number of specialists that are available. And we already have a bottleneck, right, coming in. But what's happening behind the scenes, which I didn't talk about today, is that there's a lot of work going on right now to try and really provide some evidence about what the workflows need to look like and how we can equip specialists out in the community to be able to feel comfortable and confident in making the diagnosis so that we're not having this bottleneck occurring out in the community. So a lot of work on changing those workflow patterns and public policy to make it more readily accessible for people to get into the system and to give primary care the tools so that they can do a lot of the diagnosis as well out in the community.
That's fantastic news. That's exciting.
Yeah, I mean, the Alzheimer's Association has a lot of programs right now in terms of trying to educate primary care doctors and specialty care out in the clinic. So there's a lot of work going on in this area, recognizing that having these tests is really great news because it allows us to make an earlier, more reliable diagnosis, which then means that we can get people treated and then likely, your ability to respond to a drug is going to be better the earlier it's caught. But then making sure that we've got the providers who are comfortable in caring and providing that care.
Mm-hmm. Wonderful.
Excuse me.
So if the blood tests turn out to be not covered by insurance, what are we looking at cost-wise, or the current treatments that are out there, if they're not covered by insurance, what are people looking at?
So the current drugs that are available are covered by Medicare, and the costs for those are anywhere from $27,000 a year to $32,000 a year for the excuse me, for the monoclonal antibodies, but those are covered by insurance.
Okay,
Um, excuse me.
sure.
The blood tests, I don't know what the exact cost for those will be. In the ballpark of about 3,000 is what I've heard in the past. I don't know if that's still projected to be, but hopefully that cost will be coming down.
That's good. Maybe as it becomes more popular, that will go down. Are there any other drugs that look exciting to you now that we've sort of seen, we had our high hopes for the GLP-1s? Is there anything coming right behind that that is really exciting to you?
There are a number of drugs that I find really exciting. Like you said, I think the GLP-1s were the ones that I was really excited about, and I still remain excited because at the recent Alzheimer's Association meetings, looking at that class of drugs, there was some significant work that was being done that showed a signal on cognition and on the biomarkers that were affected. And what I find exciting about that class of drugs is it's really acting on what I would call the upstream effects. So really trying to get at the root pathology before you ever get amyloid starting or tau starting. It's really upstream. So working on things like inflammation and blood flow, and other types of immunity, I think, are really encouraging because not only will those drugs have an effect potentially on the amyloid and the tau of Alzheimer's disease, but also on vascular health, as well as other factors that contribute to the symptoms of Alzheimer's and other dementia. So I found those really exciting. There's other drugs that are acting on a different biological mechanism, but basically taking basically on the translation of genes into the proteins. So there's a variety of different drugs right now that are under development that affect the translation of those proteins. So translation of the genetic code into the proteins. And those drugs actually have multiple targets. So they affect both the alpha-synuclein that's affected in Parkinson's disease, as well as amyloid and tau in Alzheimer's disease. So those particular drugs, and some of those are under testing right now here at Duke, could potentially have an effect not only in Alzheimer's disease, but also in Lewy body dementia and Parkinson's disease as well. So that class of compounds I'm really excited about because the idea that you could affect multiple neurodegenerative diseases with the same compound, knowing that these diseases often co-occur means that you're actually targeting multiple diseases at the same time. So that would be fantastic if that pans out.
Yeah, that would be amazing for so many people.
Mhm.
Yeah. Um, I'm just reading the questions. What limitations still exist with current treatment options?
The current treatments, meaning the ones that are currently available as opposed to
Yes.
those in trial? Yeah.
Yes.
So, the current monoclonal antibodies that are available, I mean, the biggest limitation I would say is that they're targeting amyloid only. And so they'll be appropriate for patients who have an amyloid problem, so have Alzheimer's disease and have demonstrated amyloid accumulation, but they won't be appropriate, obviously, for patients who don't have that. So, for the patients who have Lewy body dementia or vascular dementia, those compounds won't be helpful. So that's problem number one. It won't be for all patients. Um, Problem number two is that attacking amyloid is probably going to be effective earlier in the disease and not later in the disease. So again, it'll be a drug for patients who are very early or mild, but not going to be necessarily beneficial for patients who've progressed into more moderate stages. And third is the safety profile. So both of the drugs, uh, basically take away amyloid out of the brain, have an effect on amyloid. They also run a risk of bleeds in the brain. And so that's why it has to be monitored very closely. And people who have a certain gene type, if they have what's called the ApoE4 gene type, tend to have a higher risk for these bleeds to occur in the brain. And so those patients have to be monitored very closely and may not want to go on the drug in the first place because of that risk for a brain hemorrhage or a bleed. So that's the other problem is the safety issue. Now, typically what happens is that people who go on either of the drugs that I mentioned that are available, they're monitored very closely with MRI scans during the early dosing. If a problem is seen, they're taken off the drug and they can often be put back on it after they go on just a hiatus for a while. So it's very possible to control this problem, but still it's a significant safety concern that has to be very closely monitored. So those are the main limitations. That we would love to have a drug that you could take orally, not have to go in for an infusion. Both those drugs that are available, like I mentioned before, you have to go in for blood infusion. So we'd love it to be an oral pill. We'd love it to have a good safety profile so that we're not having to do repeated MRIs, every several weeks in the early stages of dosing.
A lot to think about.
Mhm.
Thank you.
Yeah, absolutely.
There is a question about TV advertised drugs. I get this question myself a lot. What is your opinion on the supplements or other medications that are suggested on television for people to take to help with their memory?
Yeah, that's always a great question. I never know what to do with TV ads. A lot of times I can't even understand the TV ads when they've come on there. I would say most of the drugs that people or supplements that get recommended that you might see in the pharmacy, um, they're based on the evidence that these different nutrients or different vitamins that we get through our diet can be taken in a pill form and have a beneficial effect. So there's been lots of studies, for example, that, taking vitamin E or vitamin C or taking different kinds of micronutrients might be beneficial to the brain. And I don't think there's any doubt that that's the case, that they are beneficial. But I think getting them in a pill form is not the best way of getting those nutrients. It's really through the diet. And there's been many studies that have shown this now, that when you compare people that are getting the various nutrients through their diet versus over-the-counter medications, the effect is really in the diet and not in the over-the-counter drugs. So I would always take that with a grain of salt. Also, they're not regulated through the FDA, these over-the-counter um, supplements. So again, you have to really worry about whether they're going to be effective and safe.
Mhm. Thank you. So I just want to thank everybody for joining us today. And Dr. Welsh-Bohmer, thank you for giving us your insight into not only what's happening now, but what's probably, coming in the next year. It's really exciting to have so many things on the horizon when perhaps we haven't had that much for quite a while. So exciting to hear about. And we appreciate all of your efforts in that and sharing. I do want to let everybody know we'll send this information out to them, but please do check out the North Carolina Registry for Brain Health. Check out that Lancet report to look at those modifiable risk factors. Go for a walk this afternoon. And I just want to thank everybody for a great year and for continuing to work with Dementia Alliance to create that state of caring. as we go into 2026, we're going to see big things, and it's going to take all of us to get there. So thank you, Tara, and thank you, Dr. Welsh-Bohmer, for joining us today. Thank you to all of our supporters out there. We wish you a very happy Thanksgiving, and look forward to talking to you all soon. Thanks so much, everyone.
Thank you.